Thank you very much for the organizer inviting me to this talk. So there will be a number of overlaps in my talk to the other speakers, mainly because the sequence has changed. So my task here is talk to you about dual chamber leadless pacemaker, and there's only one in the market at the moment. So which I'm going to focus on that. Beforehand, I think we should recognize the pacemaker as a treatment modality has saved countless of lives over the past decades, and it's a fantastic technology. Having said that, there are difficulties and challenges and complications from the lead-based system, mainly after some time. I think has been covered before, 1 in 8 patients with a lead-based device will have complications. Pocket infection is difficult when it comes to chronic leads. Required extraction, lead can fail, and therefore lead us to the next platform, which has been around for about 10 years or so now. It's a leadless pacemaker. Started off with NanoSim 2013, excellent a device apart from its battery. Therefore, it's disappeared for a while, and followed by Microsystem, which is a time fixation around for 10 years. We understand the leadless pacemaker, the advantages of the leadless pacemaker covered by before. Access is more versatile. It can come from the top and the bottom, and infection risk is very remote for various reasons, possibly because of no pockets, no leads, less surface area and material and so on. Because there's no lead traversing the valve, therefore, provided you place a device carefully with appropriate anatomy, not too small heart, and keep the proximal end of the lead away from the tricuspid valve, perhaps can avoid valve-related complication. Disadvantages: single chamber for many years. We can sense the A in pace to V, and there are certain limitations, has been extensively discussed before, and lack of conduction system pacing clearly is taking a large interest. At the same time, the data is being gathered. Therefore led to the talk today, dual chamber, a leadless pacing platform. There are major stepwise breakthrough from the dual chambers from a single chamber devices. Number one is first time that there is atrial device, pacemaker. So therefore understand anatomy and how the device interact with the atrial chamber and surrounding structure is so important. And we've done a piece of work before the launch, looking at the wall thickness of the human right atrium from a 25 cadaver heart from Yan Ho, our collaborators in our hospital, which and also 100 patient MRI scan looking at the right atrial anatomy, the shape, and also computer modeling to look at the interaction of this leadless with the surrounding structure. And we found that the best place to place is that base of the appendage. And if that's not suitable, perhaps the lateral wall, the thickness is more or less and can accommodate the 1.63 millimeter of the helix depth. To avoid aorta, for example, at the tip, you can cause aortic damage when you go too deep inside, or the phrenic nerve and the right atrial proper. So the second leap in this technology is from the engineer they found a way to communicate between effectively two independent pacemaker and what also called eye-to-eye communication, and they have achieved a very consistent communication between the two devices, over 90%, with some use of the battery. So here's the data. You're all familiar with the IDE study that's published about a year or so ago. 300 patients, 53 centers, 82 physicians. The design is purposely to give it to a wide range of different hospitals where almost all of them have no previous experience in implanting at least an HO device in humans, and to look for whether this is feasible in a more akin to a real world, but maybe all more expert centers. And you can see the acute successful implantation rate is very high. The complication rate is reasonably low. Some dislodgement, 6 patients, 5 atrial, 1 ventricular. This is the very, very early experiences, and I think most centers implanting dual chamber VIA now have experienced less. 2 pericardial fusion, one of which has to be drained, the other one was managed conservatively, and the eye-to-eye communication was excellent. So this is a very good, encouraging first piece of information suggesting the feasibility of this platform in human, at least at acute implantation. So what are we using these devices in patients? And here's an example. We have a large congenital population. Therefore, I'll show you a congenital case, a 26-year-old man who has serious a cardiac operation with a anatomy of a double inlet left ventricle, transposition of aorta at a gland procedure, which is SVC to pulmonary artery, a connection. So a pacemaker was, AV blocks very common in this population. A pacemaker was implanted at ages 11, and where the atrial lead is placed just above a patch where it's just atrial sensing and pacing, and the ventricular leads through the puncture through the patch, pacing the ventricle. So 10 years later, it has failed, and make a very via the dual chamber pacemaker make a very complex situation very simple, where we can implant 2 devices through the femoral roots without much difficulties. And there is also a subcutaneous RCT for secondary prevention in this particular patient. So access is from the femoral side very straightforward, particularly for the atrial implants in this technology. Infection risk is very low, therefore we frequently implant this after lead extraction without have to wait for a long time. So shorten patient's stay in the hospital, which is quite helpful. Patient with hemodialysis at risks of infection, sharing the same channel where they have the dialysis port with the lead-based system, leadless would be of an advantage, which we frequently use in this population. Patient choice, really. More people learn about dual chamber pacing technology, and they come knocking on the door asking for one. I think it would be very difficult to turn them down unless there is a very good reason to do so. And we're going to talk about the battery longevity of AI maybe in this slide. The battery remains an issue with this new technology, particularly coming from the atrial pacemaker, being smaller, the ventricular pacemaker. So therefore, the real estate for battery is rather limited. Now, for example, if you pace 100% of the time, base rate of 50, dual chamber mode, DDR, with a reasonable threshold pacing output of 1.5 at 0.4, that's only 5.8 years with the current system. Okay, clearly this is suboptimal compared with what we know of the lead-based system. Therefore, a series of interventions has been implemented. One is to increase the battery capacity. And there's a 30% increase in the next generation, just around the corner, with the same size of HO device. Programming, disengage the HO to the ventricle for patient who that's not required ventricular pace a lot of the time. The pacemaker can be paced independently without the use of any battery for eye-to-eye communication. That will save quite some years, as has been described before. So with these maneuvers, the HO, a pacemaker longevity can be improved. Of course, more work needed to be done further down the line, potentially with the better a battery technology that can help things. Remote monitoring is around the corner. Next year or so, we'll see that in this platform. Although there's not a lot of data can be captured by the device, so remote monitoring data coming through may not be as meaningful as lead-based system. Nonetheless, it's a comfort to the patient knowing that it can be monitored remotely. Extraction is possible, and thanks to the nanostim data that we know that it can be extracted. Therefore, maybe younger patient is of an advantage of having a device that's more easily extractable with a purposely built extraction kit like the tri-loop snare and so on. And this has been covered before. And this slide has been shown a few times now. The conduction system pacing of this active fixation mechanism has been reported. 14 patients enrolled, 10 patients eventually had a device screw into the septum, and only 5 of those patients was able to achieve left bundle area pacing, which is a feasibility showing that it can be done. All these devices were explanted immediately after implant. These are not a fully fledged a permanent system, so we have to recognize that. So this is the first step to show its feasibility, mainly because in the animal model it's rather poor, because not representing the human morphology, where this study has to be performed in a country that can be done, but here we are. So more to come in this area, and if we can crack this nut, I think the future of Leadless is more rosier moving forward. Now, what we don't know is, so summary slide here, if I can say that my topic is about dual chamber leadless pacemaker, is a leap in technology of pacing. It's the first HO leadless pacemaker. The communication between different chambers, different pacemaker, I think is phenomenally important if we want to advance this field further, and it has achieved that so far. The conduction system pacing around the corner. Battery longevity remains an issue, and that is perhaps ought to be a fully addressed moving forward. Different technology, I'm sure, future innovation will help us to improve that. The device function, we are not sure about the HO device function over time, whether it can be retrieved or not. So long-term data definitely is required. And we have set up a UK-based registry, including all 4 nations of the United Kingdom, where we will plan to enroll 600 patients and follow up 5 years to look at how the device behave in a longer period of time, hand in hand with other registry in Europe and in France and in the Benelux. So these are the Europeans and UK efforts try to look at this technology a bit more closer in the real world and environment. So I will stop here. I think I'm in time just.